Well, I think it's pretty straightforward because the bulk of patients start off with relapsing MS. You're talking about 85 to 90%. Only a very small minority start off with progressive MS. Now, ultimately, untreated, every relapsing MS patient is at risk to become progressive, but that's typically some years into the disease. So when people started to try to develop treatments for MS, they focused on the major form of MS, which is relapsing. This is interesting, and I think the current thinking is that there really aren't qualitative differences between primary progressive and secondary progressive. I think that's being emphasized here. We think about progressive MS, gradual worsening MS, as reflecting the clinical features of the neurodegenerative phase, injury to axons and neurons. And I think the current thinking is that the substrate is basically shared for primary progressive and secondary progressive. There are some maybe quantitative differences as opposed to qualitative differences. I've heard that stated a couple of times in the talk so far. I think from a meeting like this, it's very important that important knowledge be disseminated in a meaningful fashion to the non-MS expert physician, who very many of them are taking care of MS patients. So they need to kind of understand what's the important new concepts that may come out of a meeting such as this. I think we're recognizing the importance of treatment in MS. We're the major neurological disease that now has multiple disease-modifying therapies. No other major neurological disease comes close, but that also means that it becomes very complex. And I think as some of the newer agents come aboard to determine who is eligible for them, who should be offered that treatment, how do you evaluate risk-benefit ratio in a treatment that may be highly effective but perhaps carries a little bit more risk or hasn't been on the market a long time. That's where using the expertise of very knowledgeable neurologists with regard to MS can be helpful to the practicing neurologists where they don't really have a specialty interest in MS. You know, you'd be surprised that you can see poor care even in areas where you would expect it should be very good care. And I think it really boils down to how knowledgeable the physician may be about a disease that they may not have any particular interest in and perhaps only accounts for a fraction of their patient base. And so I think it's very important, there's a responsibility, particularly in a disease like MS where there are treatments and where choosing the right treatment early on can really make a huge difference for the patient, that if someone doesn't feel comfortable with that, they should get an outside opinion. They should get an opinion from an MS expert or an MS center. And we do have a lot around in urbanized areas such as the Northeast and around New York, but you would be surprised at some of the suboptimal things that can happen. I think that we should be optimistic with the major focus on progressive MS, the possibility that we may have our first treatment perhaps in the next year or so. Certainly it's going to be submitted. I think we're getting a better understanding that inflammation definitely plays a role in progressive MS, not just relapsing MS. I think we're looking at perhaps better markers. There's a new emphasis on the fact that there may be inflammation of the meninges that plays an important role. I think we're getting a better understanding perhaps of the immunologic and genetic and environmental factors that play a role that might lead to future manipulations or treatments. So I think just a sense of optimism. There was even a very interesting little study, premature, where they looked at treadmill exercise as having a positive benefit on cognition. Cognitive difficulties are a symptom issue that can occur in MS and can occur in progressive MS. And can exercise really benefit that? Very interesting question.